I now request Dr. Kaustav sir to proceed with the rest of the session.
Thank you so much for the wonderful conduction of the inauguration ceremony, Shagnik. So, proceeding to the academic sessions again, may I please call upon Dr. Sanjay Kumar Pandey and Dr. Kaustav Basu Thakur to chair this session, which shall feature someone whom I call my third eye, because he gives me so wonderful ultrasonographic reports, which helps me to see deeper into the tissues. Dr. Shan Das, and the second speaker would be Dr. Reshmi Rungta, who is the SR in Rheumatology, but her qualifications are such that we could not fit it into the small box over here at the program. So we just wrote faculty, but they shall be introduced. So over to Dr. Pandey and Dr. Basu Thakur for the proceedings.
We'd like to welcome our first speaker, Dr. Shayan Das, who is a consultant interventional radiologist at the PLS Hospital, Kolkata. He'll be speaking on musculoskeletal USG.
Very good morning to everybody. Actually, I'm not dealing with the general musculoskeletal ultrasound. It's just to make aware of the machines, what it is capable of. Now, I'm talking few words about the Rheumatology, that is to optimize the image. Now, in CT scan, MRI, these are already optimized with artificial intelligence, and there are newer software which has been incorporated in the machine. So, if you plan well, the machine calculates the optimization by itself. But in ultrasound, is vastly dependent on the operator. So, handling the ultrasound machine is the handling a digital camera with a manual mode. So where you can adjust the light, exposure, time, focus, depth, everything. So first we have to choose the transducer. You have to know which depth you want to visualize. Just if you want to visualize a deeper structure, you take a low frequency transducer, so the penetration will be better. If you want to see the superficial structure like median nerve and the wrist joint and all, you have to take the high frequency transducer. So usually we use about 5 to 12 megahertz transducer for our musculoskeletal ultrasound, and for the deeper part like psoas, hip and all, we take the 2 to 5 megahertz probe. The idea of optimization of an image for intervention and for the diagnosis, your focus of the part should be about a 2/3 of your screen. So you take the deep and the surrounding tissue for 1/3 of the screen, and main focus should be 2/3 of the screen. That gives you a better zoom and the visualization of the structure. Now, these are the 3 transducer we have in our department in a machine. You see this is one C51, that is 1 megahertz to 5 megahertz probe. That is for the deeper penetration. This 312, usually it was 512 in our textbook. That is just, they have made a bit differently. So it's a 312 probe. You see the deeper structure, and this E418, that is the, they call it as a HD probe for the superficial structure. This 12.3 and 418 doesn't have a lot of difference other than the tissue harmonic images and all. Both of them are almost equal. So the gain and TGC, what do you call gain? Gain is overall increasing brightness of the image. And TGC is the time gain compensation. What is that and how it is different from the gain? In TGC, you can control the gain as per the depth. So you want the deeper tissue to be more brighter than the superficial part. You increase the TGC at the lower part, the deeper part, and keeping the TGC low in the superficial part. That gives you more homogeneity, because sometimes when the patient is having a lot of fat, the superficial structures looks more bright than the deeper structure. So you can reduce the superficial TGC and increase the deeper TGC. That gives you more homogeneity. And this is the machine. You see these buttons, the left-hand side buttons, these are called TGC. There are many buttons, and all of them are pertaining to the crystal of your probe of different depth. So you can increase that. And this YOLO 2D button is the overall gain of the field. The frequency and the focus for the better resolution, if you want penetration, as I already said, you reduce the frequency. This probe 418, what does it mean? It is capable of producing 4 megahertz to 18 megahertz. Depending upon your need, you can manipulate it. There is something called focus. All the machine, I go back to the previous slide, you see on the right hand side there is something, a knob called focus. This focus is a arrow. You can increase or decrease according to your area of interest. You want to see the wrist, but you are trying to focus the deeper part of it. You put this focus, rotate it and put it down at the deeper part. That will give you a better resolution. And if you want to see the superficial part, like neurinoma or something, so you put it in a superficial part. So deeper, the maximum frequency of the probe would be generated to your depth and the focus point. Dynamic range imaging and tissue harmonic images, these are to improve your image quality. That makes more homogeneity, reduces the noises, and increase contrast between the tissue planes. And few words about the recent advances is the artificial intelligence. Now, ultrasound machines are also incorporated with artificial intelligence. Again, I go back to the ultrasound module. There is something called a button eye scan. You do not do manual modulation of your digital camera. You put it in auto mode. You press that eye scan. It will almost optimizing your images. You may like it, you may not like it. Then also you can modulate it according to your need. So this comes with the artificial intelligence. It reduces the operator variability. Few words about elastography. Now, elastography, we use two types of elastography. One is shear wave elastography, one is strain elastography. Now, for the musculoskeletal point of view, we used more of the strain elastography, and the shear wave we use for the deeper tissue because it does not have a superficial temporal resolution. So elastography will tells you about the toughness of the tissue. Now these are the two pictures. On your left hand side, this is called confidence map. Now what is confidence map? The green are the best area. You keep your area of interest to the green part. Yellow is considerable, but the red is not. So there are a lot of artifact will be generated in the red. The bones and the blood vessels comes in the red zone. So we don't calculate things over it because on strain elastography, what happens is it doesn't change its shape. The concept of elastography, you give a high resolution frequency of a sound wave that distorts the tissue, and the tissue comes back to its normal, liberating the energy. The tougher tissue are tough to distort and they comes back delayed. The softer tissue are easy to distort and they comes back to normal very easily. That's why the concept of elastography is been given here. So the bone and the blood vessels, blood vessels are pulsatile structures. So never keep the normal shape always. And the bone are toughest one because they do not change their shape on elasto. So they are predicted as a red one. So we put our interest in the green or a yellow zone. Now on the right hand side, this is the elasto map. The blue are the softer and the red are the tougher structure. Now you see in between there is something red lying in between. That is the fascia between the muscle, which is relatively tougher than the muscles. So they are shown as red. The muscles are shown as sky and the blue, and the fat are also showing as the sky and yellow, depending upon the compression. Now on elastography, it is very important that you must have the optimum compression. If you compress too hard, everything looks red. So distortion doesn't happen. You have to allow the tissue to have the distortion and comes back to its normal position. How do you measure whether your compression is optimized? You have to see the superficial layer. This part is the subcutaneous fat. This must not have any indentation of your probe. If it does have, the edge of the probe shows a black echo drop. If you do get that you are compressing too hard, release it. If there is a echo, that is bright spots lying in between this fat and your transducer, that means you are compressing too light, too superficial. So the air bubbles are allowed to float within your probe and the skin contact. It is homogeneous. When the compression is homogeneous, you see the horizontal line because there is no distortion of the superficial fat. That is the optimum compression you can give, as because it is have a interoperable operator variability. So these are very important tools before diagnosing something. So on elastography, we take two things. One is size ratio and the strain ratio. Either or is more than one than the normal tissue. These are the tougher structure we are discussing about, and usually they are malignant. So few words about the power Doppler. Power Doppler is you used to apply for the small low flow vascular imaging in case of small joint arthritis, neovascularization. These are independent of the flow direction. The usual Doppler is dependent on the flow direction, but these are independent, but they pick up very low flow. There is no angle correction needed for the power Doppler. Now in this image, you see there is lot of artifact around the joint because these are the muscular vessels and these are the joint. This is the wrist joint and this is the synovium. You can also take the spectra from this to rule out whether it is artifactual or it does have a spectra. Usually these spectras are biphasic with high diastolic flow, shows the inflammation. The high resolution and dynamic images, again it's I have already shown the high resolution probe. It's just the crystals are different and the filters are different. The probes are a bit costly, but that gives you a good images. Miniaturization and point of care. Unfortunately, this scope is not available in India because of PCPNDT Act. You cannot register a probe which is handheld or pocket friendly. You must have a stationary machine in your institute so that you cannot. The point is you should not use this probe for diagnosing something else. But this is very handy. You put it in your pocket, go to your ward, just check the ultrasound, it connects to your phone, and you can diagnose by yourself and give whatever you can, remedy can give in. And few words of intervention is the regular ultrasound intervention, and you can also use the contrast enhanced ultrasound thereafter intervention. The newer modality is the fusion images. You can load your CT or MRI data on your ultrasound. There is a stationary table which actually calibrated same as your MRI or the CT table. Now there is 3-point immobilization. That means 3 anatomical structures. First you have to identify on your probe. That's actually calibrate the patient with the machine and the images. Thereafter, you put your ultrasound probe on the shoulder, you are pointing somewhere in the shoulder, and that shows on MRI which area you actually pinching on. And after that, you can decide your intervention. That means, suppose I want to block a suprascapular nerve. Now on ultrasound, I am seeing the groove and I am putting my needle in. Before that, if I indent there, whether it is really suprascapular nerve location or I am seeing something on ultrasound predicting is a suprascapular, actually which is not. So on fusion images, we can actually see that and can precisely produce our therapeutic effect. That's all for the Nobology and the recent advances. Any questions I'm happy to take, sir. Sir.
In case of rotator cuff tear, particularly spinatus,
Yes.
the partial tear, the measurement, how many millimeter should be demarcated for conservative treatment, and above that we'll go for the surgery.
Usually, sir, it's less than 1 centimeter. We take it for a conservative therapy. More than a centimeter with the tendon retraction, more than 30% of the tendon bulk retraction, you can go for a surgical management. Thank you, sir. Sir.
Osteoarthritis shoulders, like in frozen shoulder, from the desk, what do we go for an investigation? Is it USG, HR USG or MRI? I mean, which would you prefer considering the cost involved?
It's always a USG with a dynamic movement that gives you the story about impingement and the bursal status. MRI we do for particularly to detect the tear, detecting the glenolateral architecture, because in ultrasound the labral architecture is not very well seen in cases because there are a lot of osteophytes around the joint. But if you think there is a stiff shoulder, it's always good to have an ultrasound beforehand proceeding for a MRI.
Thank you, sir.
Dynamic. All the shoulder ultrasound, I think it should be dynamic. Because the patient is live, you are standing there, it's a real time, always have a dynamic ultrasound. There is nothing called a non-dynamic ultrasound of shoulder, right?
Thank you, Dr. Das.
Thank you.
Really, it's a wonderful session. And as you said, this elastography thing. So I don't actually, elastography property of musculoskeletal ultrasound machine which we are having, whether we are utilizing that property, whether we are utilizing it or not. Is it available in all the machines, this elastography property or resolution of, or is it different, this MSK USG specification you are having with you?
No, you have to take it separately. It comes as a separate software. Usually these probes are supported with the hardware. Nowadays all the machines have a elastography beginning from the range of 20 lakhs or so. So the middle level machines up to the top level all are having a component of elastography. You have to opt it. In musculoskeletal ultrasound per se, the elastography utilization is not very much until otherwise you have a median nerve neurinoma or a synovial cyst which is looking as infected synovial cyst. These are not anechoic. They are having echo. You are confused that what is it? Is it synovial? Is too tight, tense synovial cyst? Then elastography have a role to play. Otherwise, mostly elastography used in our practice for the breast ultrasounds, for the thyroid ultrasounds, and for the liver elastography.
Yeah, that we need to venture off as a physiatrist. And next thing, what about this prognostic implication of this MSK USG? Like suppose we have a young patient with a TFL tear, and can we decide whether the tear tendon is healing on the phases, different phases of healing through MSK USG? Then can we delineate the phases of healing of these tendons, because it is cheaper rather than doing MRI.
Yes. Yes, you can always see that, because in acute injury, what you see, the tendon is echogenic. There is a lot of anechoic fluid around the tendon. Once this is in a phase of healing, first the fluid will go. The echo remains in the tendon. Then it comes back to the isoechoic. Isoechoic means it's the same echo texture of your nearby adjacent tendon. Then it remains hypoechoic for the rest of the life because it gets scarred.
It is very important for us because the players always give us a tremendous pressure to return to a sports. So as a PMR specialist, giving them fitness, return to fitness or return to a sports after having this injury, and we want their rehabilitation phase to a little bit prolong, and they have a pressure to return to their performance. So we need to know quantify rather the whatever the regeneration process is going on with the tendon. So I think it is helpful for us also.
Yes, yes. You can always see that. The only thing to rule out the partial tear, you always have to strain on the tendon. That means if it is a bicep tendon, then you ask the patient to flex the arm. So you put your transducer at the myotendinous and the osteotendinous junction. You see the contour deformity. If it is homogeneously contracting, that means there is no tear per se in the muscle. But if something is contracting but the rest of the thing is retracted back, then you know there is a partial thickness. If it is full thickness tear, problem is solved. You know offhand there is a full thickness tear. The only issues is the partial thickness tear of a deeper or a superficial fiber that gives you the inhomogeneous contour deformity on strain. That is also the important.
Sir, I want to ask one question that you mentioned about the handheld devices which are still not available in India.
It is available, but it's illegal.
So are we anywhere near, like for physiatrists, our stethoscope sometimes becomes the MSK ultrasound. So how
actually,
in the future what we see?
The issue is the PCPNDT Act is made to protect the female infanticides. Right. Now, issue is, as a physiatrist, you are having the probe, you are doing a good job. That's a part of the business. But the illegal utilization of these available probes, there is no bar in our country that you get it, some other will not. Now, they will hold the probe in their pocket, go to the villages in the room, in different houses, diagnose the sex of the fetus, and
actually it's such an interesting talk now. It's a discussion can go on and on. So we have to conclude here,
yes.
But we can discuss it all together in the present. Thank you. Wonderful session. Wonderful talk. Now I would like to invite Dr. Rasmi Rungta, Faculty Department Rheumatology, SSKM Hospital. It's over to you, Dr. Rasmi.
Thank you, sir. Good afternoon. It's a pleasure to be over here. Thank you to the organizers for having me here. I'll try to discuss musculoskeletal ultrasound and rheumatology. Nowadays, there are a lot of practical implications. I'll touch upon the major aspects of it. I think I'll skip this because Sir has already covered this about the basics of the machine. So yeah, I'll start from here. So how do we use ultrasound in rheumatology? So it is to diagnose articular and periarticular inflammation. We can check for subclinical and early arthritis in patients who come with polyarthralgia, where we are not clinically being able to diagnose whether they have evident arthritis or not. And sometimes it helps us to differentiate whether the pain at or near the joint is articular or due to periarticular pathology. Like it could be tenosynovitis, tendinosis, it could be a bursitis. So that ultrasound really helps us in that. So, but it does not help us to differentiate between rheumatoid arthritis and psoriatic arthritis, except maybe gout. It helps us to diagnose, but it won't help us differentiate whether it's psoriatic or rheumatoid. That would be a clinical decision based on the number of the area of joints involved and all. In our large vessel vasculitis, we use ultrasound to look for Takayasu and giant cell arthritis. We also do a lot of ultrasound-guided procedures, joint injections, especially hip, shoulder. Ultrasound really helps us reach the accurate point. Injections around tendons. We do carpal tunnel syndrome, bursitis, barbotage, and calcific tendinitis. It helps us differentiate between a ruptured popliteal cyst and DVT because they can present similarly. And for monoarthritis, where we're suspecting TB or any other infection, we can do synovial biopsies and muscle biopsies in case of myositis, especially focal myositis. So the structures evaluated are the synovial membrane. We check whether there's an effusion or not, the tendon surrounding the joint, regional musculoskeletal pathologies like de Quervain's and tennis elbow, and bone erosions which suggest chronicity. So moving on to synovitis, in the left picture, in the left picture we can see a normal wrist joint. This is the lower end of the radius, this is the lunate, this is the capitate. The T is the fourth extensor tendon running on top of the wrist joint. This is a longitudinal scan of the wrist joint. And over here we can see that from the radiocarpal and the intercarpal joint, there is a hypoechoic structure which is arising out of the intercarpal and the radiocarpal joint. So this is the synovium which has come out. So there is synovial hypertrophy over here. So this is an abnormal ultrasound scan. So the synovial hypertrophy can be graded based on the Omeract scoring. So this is a metacarpophalangeal joint. So we can see that there is no synovial proliferation here. This is grade 1, where the synovium is under an imaginary line joining the two adjacent bones. So this is grade 1 synovial proliferation. Grade 2 is when it crosses the imaginary line, but the top of the synovium is still flat and it is not bulging. And grade 3 is when it crosses the imaginary line and is bulging. So there are 4 grades of synovial proliferation. So this is our departmental image. This is again a longitudinal scan of the wrist joint where we can see grade 3 synovial. This hypoechoic area arising from the intercarpal and the radiocarpal joint is the proliferated synovium. And this longitudinal structure running on top is the fourth extensor tendon. So there is grade 3 synovial proliferation here. This is another wrist joint scan along with the color Doppler on. So vascularity can also be graded 1 to 4 based on the Omeract scoring. It's a bit complicated, but over here we can, since it occupies less than 50% of the entire box, but more than 3 signals, this is grade 2 vascularity. And we can see erosions over here. There is a discontinuity in the bone, along with grade 2 synovial proliferation. And this is the same wrist joint in the short axis. So we can see the end-on view of the fourth extensor tendon, and there is synovial proliferation and vascular uptake over here. So how do we detect erosions? Erosions is any discontinuity in the bony surface. So this is a metacarpophalangeal joint. So ideally this should have been straight like this, but we can see a discontinuity in the bone. So this is called an erosion. But to say definitely that it's an erosion, we should look at it in 2 planes. So this is the longitudinal scan and this is a transverse scan. So in the transverse scan, we can see the same erosion in the transverse view. So only after seeing it in 2 perpendicular planes can we call it an erosion. So ultrasound is very specific for diagnosing erosions. So moving on to other pathologies. So this is a longitudinal scan of the knee. So this is the lower end of the femur. This is the left quadriceps tendon. We can see the probe placement over here. And there is a hypoechoic area right under the left quadriceps tendon. So this is basically a fluid, a suprapatellar bursitis in the left knee joint. So sometimes it is difficult to differentiate whether the hypoechoic area around a joint is fluid or synovial proliferation. So a few things helps us to differentiate. First of all is compressibility. So if it is fluid, it will be compressible. If it is not, if it's synovium, it will be non-compressible. Synovium might take up a few Doppler signals. Fluid will never take a Doppler signal. And fluid will be displaceable, which is why it is compressible. Also, fluid is definitely more hypoechoic, and there might be echogenic areas in a synovium. So this is actually one patient of ankle joint. So we thought that this on this image it looks like there's gross synovial proliferation in the tibiotalar joint. But then if we look closely and with the Doppler signals on, we realize that there's actually quite a lot of effusion. And there is some part of synovial proliferation, but there's a lot of fluid also over here. So both can coexist also. So moving on to tendons. In the long axis, tendons look like multiple closely echogenic parallel lines, and in the transverse axis, they look like echogenic dots or lines. So this is tenosynovitis. This was an RA patient with anterior ankle pain. So this is the tibialis anterior tendon, and we can see fluid around it with vascular uptake. So nerves also look kind of similar to tendons, but there are a few methods to differentiate nerves from tendon, which is honeycombing in the median nerve. A tendon moves more with wrist movement than a nerve, and anisotropy is more evident in a tendon than in a nerve. So we usually do scans of median nerves in rheumatology practice. Over here you can see a median nerve in long axis, and over here in short axis. So the area over here is 0.14 centimeter square, which is pathological. So because she had CTS symptoms, we ended up giving a steroid injection perineurally in this case. So a few cases. This is a 43-year-old female who was referred for hand joint pain. Her lab tests were inconclusive. So we can see that as compared to the normal scan, there is grade 3 synovial proliferation over here, along with some erosions. So it was clearly a case of inflammatory arthritis, and we started her on DMARDs. So this was a 55-year-old male with pain and swelling of multiple joints only for 6 months with numbness and deformities. So the wrist scan was showing features suggestive of inflammatory arthritis, but the median nerve area was almost 0.22 centimeter square, and this turned out to be leprosy on split skin smear. So this was a 50-year-old man with pain and swelling of the wrist joint, and on ultrasound we saw tenosynovitis. It was isolated fourth extensor tenosynovitis. So this is the short axis view of the extensor digitorum, and it was quite vascular. So it could be infective, it could be because of early arthritis. That only clinically and labs we can evaluate. This was a 35-year-old manual laborer with a right wrist swelling. So we can see a well-delineated hypoechoic structure over here, suggestive of a ganglion cyst. We can see that the soft tissue underlying the ganglion cyst is quite echogenic. This is because of posterior acoustic enhancement. This is a 55-year-old lady with pain and swelling at the lateral aspect of the wrist joint. She was also a diabetic. So over here we can see that on scanning the lateral aspect of the wrist joint in the longitudinal axis, this is the first extensor compartment. There is a lot of fluid around it along with vascular uptake. So this was dequervin tenosynovitis, and we injected her over here, and she was completely relieved of her pain. This was a middle-aged male with rheumatoid arthritis, and he was unable. He had a finger drop of the fourth and fifth finger. He was unable to extend it. So this is at the dorsum of the hand. We had done a scan of the extensor tendon, so we can see that this is the extensor tendon. Over here, there is a defect in the extensor tendon. There's a hypoechoic area over here. It should actually look like this. So this was extensor tendon rupture of the fourth and fifth slips. This was a young male with a painful swelling of the posterior aspect of the right elbow. This is a transverse scan of the posterior elbow. This is the triceps tendon, and we can see a hypoechoic collection over here, suggestive of olecranon bursitis. So a few cases of heel pain. So over here, heel pain can be because of multiple causes. This is a small retrocalcaneal bursa in the long axis and the short axis. If it's too symptomatic, we can always inject it from the lateral aspect of the heel. Then this was a case of psoriatic arthritis with severe knee pain. So we can see that the tendoachilles inserting into the calcaneum, there's a lot of irregularity, there are a lot of erosions, enthesophytes, and calcific deposits inside the tendon, suggestive of Achilles tendinopathy. This was a sports person who had come with heel pain. So we can see that the insertion is fairly clear over here, but over here we can see a hypoechoic area along with swelling of the tendon. And in the short axis, we can see this hypoechoic area. So it's basically focal tendinosis of the Achilles tendon. This was sole pain. We can see that this is the plantar fascia. It's quite thickened over here. It was around 13 millimeter in this case. Shoulder joint is slightly difficult for beginners, as we discussed previously, because of multiple scanning planes and dynamic maneuvers. But we can diagnose tendinitis, bursitis, effusions, tears on shoulder ultrasound. Just covering one case. This is the short axis view of the biceps tendon, where we can see fluid surrounding it with a lot of vascularity. We ended up injecting this case. So crystal-induced arthritis, a 65-year-old male with recurrent attacks of pain and swelling. of the first MTP joint, we can see over here a very clear DC sign. So we actually scanned other joints. So this was the knee joint, which also had a DC sign. His main symptom was in the foot. So the right MTP was normal, the left MTP, the left ankle joint, talonavicular, and even the cuboid, all of them were showing DC signs in this case. Sometimes the DC signs may be absent, but there will be a lot of echogenic material, which is nothing but the uric acid crystal, which can give a snowstorm appearance with a lot of vascular uptake in the MTP joint. So this was a patient with calf pain. So basically this is a transverse scan of the posterior knee between the semimembranosus and the medial head of the gastrocnemius. We can see a fluid-filled structure. This was a ruptured Baker's cyst. We can also detect vascular pathologies. So we had a young female with absent lower limb pulses and tenderness over carotids. So this is the left common carotid artery. We can see as compared to a normal artery where the lumen is so thick, over here the lumen is narrowed and the vascular wall is quite thick in her case. So this will be more evident here. The upper images are abnormal and the lower ones are the normal. So we can see that when we switch on the Doppler, the entire lumen is filled with the color. But over here we can see that it's quite narrowed and the hypoechoic area is the thickened wall. So in summary, it definitely offers added advantage to clinical examination and it's useful for various interventions and diagnosing pathologies. It can be repeatedly done for monitoring, and guided procedures can be done in the same setting. Thank you so much.
Question from audience?
Thank you very much for your very elaborate and nice, simple question I am asking.
Thank you, sir.
The very early stage of rheumatoid arthritis, with the help of high resolution ultrasound, within how many days it can be detected?
So within how many days, sir? Sir, I think with the onset of symptoms, in a couple, maybe in 2-3 weeks, we can detect early synovitis, especially if we look for specific areas like... Sir, erosions will take at least 3 months to develop. Before that, in early arthritis, we look for synovial proliferation and vascularity. Even tenosynovitis develops early, but erosions usually develop only after 3 months. 3 months, sir. 3 months. In untreated cases, sir.
Very nice presentation. Like the cases you shown here, the retrocalcaneal bursitis, this olecranon bursitis, and this DQ. So in our practice, actually, what we find, this is not one-time event. So I think you have done also the follow-up of those cases.
Sir. Yes, sir.
So any particular thing to add in the follow-up cases regarding the relief of pain or recurrence of these conditions?
Sir, we can offer them a splint, like in case of carpal tunnel or in case of DQ-Edwards, we can offer them a wrist splint. But these do reoccur, as you're saying. We usually try to not inject the same area within at least 6 months. But if the patient is too symptomatic, we can re-inject after 3 months. But sir, apart from injecting, we always do ask them to visit a rehabilitation specialist so that the root cause can be identified and treated.
Yes, that's true, ma'am. Actually, I wanted to come to that point. Basically, these patients needs long-term or short-term rehabilitation.
Absolutely, sir.
Because in case of retrocalcaneal bursitis, as you said, we need to evaluate the type of footwear, what kind of footwear they are wearing, in what profession they are, and continuing with their profession, what kind of footwear we can suggest to them regarding the table work or sitting job for olecranon bursitis.
Yes,
and DQ.
Yes,
the use of mobile is also a very good predisposing factor for this typing on WhatsApp and with using the thumb.
Yes, sir.
So all these cases
we always
need
do refer them
yes,
to
yes, yes.
PMR, at least in our
Yeah,
hospital,
true.
so that they can be rehabilitated.
And also the primary causes in case of DQ, whether it is hypothyroidism or this many other predisposing factors.
Or diabetes, yes, sir.
Yes. Very nice. Thank you so much.
Thank you so much for the lovely presentation. I think importance of orthosis can also be impressed upon, like for long-term prevention, giving the medications, DMARDs you are giving, but for long-term we can think of other regenerative therapies, like we can go for prolotherapy or PRP, we can think of
Absolutely,
that.
yes, sir.
Because you have like steroid relief will be only short term.
Yes.
So
we don't do PRP in our institute, so I didn't touch upon that. But I think a lot of physician doctors do PRP
exactly.
therapy.
So we
yes,
can think. So what sir said about the long term. So orthosis and everything. We can conclude. Yeah, we are running short of time, so we'll try to conclude the session.
Thank you so much, respected speakers and chairpersons, for this very illuminating presentation on musculoskeletal ultrasound.